We're short, but any questions? Thank you very much. That was wonderful. Our next speaker will be David Morris, talking about whole blood transfusions. After that, at 9:30, we'll have a break. You'll be able to go to the displays, and then that will give you time to get excited about the posts and the posters. There are posters. They will be at 10 o'clock. They will be both MD level posters, and also we have a number of posters from our Weber State students. Thank you, and you're on.
Okay, great. Well, thanks for the opportunity to be here. This is great. I get to come and be an evangelist for what I hope is a shift back to an older paradigm. For those who may not be familiar with me, probably most of you, I grew up here in Salt Lake City, but then I did medical school here at the university, but then I went away for the remainder of my training. So I just came back to Utah a couple years ago, and since then I've been trying to develop a whole blood program at Intermountain Medical Center, and I'm happy to say that we finally have it up and going. So I want to kind of talk about some of that, and hopefully talk about the paradigm of how we resuscitate massive bleeding patients. Unfortunately, I don't have any financial relationships to disclose, but I do have a passionate, obnoxious interest in this, and so I'm going to do my best to stay under my allotted time here. This is adapted from a talk that I've given a few times up at the medical school that I call Holy Buckets, because it's really the concept of it doesn't matter what fluid you pour into a bucket if there's no bottom in the bucket. And so hemorrhage control, surgically, pressure, whatever you need to is more important than the fluid that you pour in. Just to frame the discussion a little bit, I want to make sure that everybody's aware that we're not talking about the patient in the hospital that has a low hemoglobin after several days of hospital vampirism or anything. This is the situation we're talking. We're talking about massive blood loss, and hopefully it helps you frame this argument a little bit if you know that is my medical student at the time sewing up a clamshell thoracotomy. Obviously, this is a post-mortem photo, and that's really the concept. That's the idea that we're talking about. We're talking about massive hemorrhage, patients who are bleeding out. This is not sort of the maintenance transfusions or even things related to myelodysplasia or those kinds of things where you get bone marrow suppression. This is massive bleeding. But I would argue that it doesn't matter whether it's trauma, as in this case, or if it's massive GI bleed or peripartum hemorrhage. The principles are probably the same. Well, if you look at all injured patients, only about 1 in 400 will die. By the time you get to hospitalized injured patients, that number gets up to 1 in 50. And by the time you look at transfused patients, it turns out that about 1 in 5 will die. So obviously there's a correlation between requiring blood and mortality. If you get to massive transfusion, which has sort of arbitrarily been defined as 10 units of blood products within 24 hours, or probably a better version is 4 units or more within 1 hour, then you're looking at an additional doubling of mortality up to 40%. And in some centers, that's even higher, depending on how you stratify that. And this is true across the board, whether you're in the military, whether you're in civilian world. Basically, your need for blood transfusion is a marker for severity and an indication of a higher risk of mortality. Now, this is a picture from back in the day. This is a bunch of nurses. I believe this is British Army blood supply, and what they're doing is they're preparing whole blood in citrate into glass bottles, and this was the state of the art for blood transfusions up really until the Vietnam War. In fact, it's said that at the end of World War II, the United States military had prepared something like 45,000 bottles of whole blood in preparation for a planned invasion of the main island of Japan, that then was wasted, obviously, after the nuclear bomb went off and the war ended. Well, that paradigm of whole blood was with us and was the state of the art for many years, up until really, like I said, the Vietnam War, when centrifuging the blood and splitting it into components became commonplace. What's interesting is that this process of splitting the blood and using the components separately was really based on no science that it was even equivalent in terms of outcomes or patient care, and was really a financial decision because you could take 1 unit donated from a single donor and split it into 2 or 3 different products. And so there was a very strong financial incentive to do that, but really no science. Tom Shires, he was in the military during the Vietnam War. He wrote this seminal work about shock, really sort of within the battlefield. If you're familiar with Tom Shires, you'll know that he's actually the doctor that announced JFK's death and Governor Connolly's death, operated on both Governor Connolly and Lee Harvey Oswald at Parkland in Dallas. Well, his work, what he did basically was he did a bunch of work with dogs, and he would put them into hemorrhagic shock and then resuscitate them. And what he found was that the dogs that received crystalloid first in a volume adequate or calculated to replace the extracellular interstitial volume actually survived, and those who didn't get that crystalloid didn't survive. And so that raised the concept, and basically what we all learned is that you have to resuscitate the extracellular interstitial space with crystalloid. And that's where the 2 liters of crystalloid dogma came from, was from Shire's work and some of that resuscitation. The problem is that what that turned into was an absolute aversion to using plasma and other products. And these are sort of a sampling of some of the treatises and textbooks that were available at the time, but that you shouldn't use whole blood, you shouldn't use plasma because it's unnecessary, and you should base it on laboratory values. Well, I don't know how it is in your hospital or where you work, but I'm about 45 minutes away from time of blood draw to time of getting those lab results back. And for my patients in the trauma bay, they may be a completely different organism in 45 minutes than they were at the time that I drew those labs. And so relying on labs isn't really feasible for me. Well, this led to the dogma of, everybody gets crystalloid. And one of the dogmas that came along with it was that the reason that we need to resuscitate and use blood products is because they're suffering from suffocation. They need oxygen, right? And so we all know that the way to do that is to give red cells. Well, that may or may not be true, as I'll show you here in just a second. And unfortunately, between the work of Shires and the centrifuging of blood products, what resulted is the resuscitation paradigm that I was taught, and I should say I absorbed by osmosis in my training, because I never really got a good lecture. Most of my transfusion medicine lectures in medical school were about avoiding cross-match issues. I never got a good lecture on resuscitating of hemorrhage, and this is what I learned, was when you give 2 liters of crystalloid, and then most likely what happens is you start to give more crystalloid, and before you know it, as soon as you're several liters in, then you're like, now the blood's here, or now we can give blood, so let's give a bunch of red product, and now that we're at it, okay, maybe some plasma, and then if somebody thinks about it, maybe throw a unit of platelets in there too. And this is kind of the way that we've done things for a long time. I remember proudly giving a patient 42 liters of crystalloid one night as a resident in the ICU, and I felt like, you're welcome. I saved your life, and now I think about that and I'm just horrified. Well, let me talk about the 3 great fallacies, and one is that crystalloid is useful for bleeding. Number 2, in what I call the red bias, and the last one is that PRBCs equals blood. So let's go through this. So crystalloid, as you know, will dilute your clotting proteins, and it does fill your vascular space, but it dilutes clotting proteins, and it dilutes your native blood cells. It leads to these problems that we know and are well documented: the coagulopathy of saline administration, interstitial edema, ARDS, abdominal compartment syndrome. In fact, ARDS, before it was called ARDS, was called Da Nang lung, based on the Vietnam resuscitation, because all the soldiers who survived, having gotten a lot of crystalloid, ended up with really bad pulmonary edema and what came to be known as ARDS. Well, crystalloid does do one good thing, and that it does raise blood pressure. The problem is, in a patient who's actively bleeding, raising your blood pressure is not exactly a productive strategy, right? And it may be that this is fake, by the way. Conan O'Brien wasn't really bleeding to death, but the idea of raising the blood pressure till we get to a number, I'm going to just move forward here. The idea of raising that blood pressure to a number that we're comfortable with obviously is counterproductive in many cases, and it may be that the loss of blood pressure is actually a Darwinian adaptive response to try to preserve the life of the organism. So raising the blood pressure until you've filled the holes in the buckets actually just results in worse bleeding. One of my good friends actually, he's famous for saying this: the only pre-hospital fluid that has been shown to improve outcomes for petting training trauma is diesel fuel. In other words, you get them to the place where they can surgically take care of them as soon as possible. Now, I would argue with this a little bit that maybe that some of the products that we're hoping to start using in the pre-hospital environment might actually make a difference, but haven't proved that yet. So, Be okay with blood pressure being a little bit low. I'll move on from there. Next is the red bias, and it kind of goes together with the third one of the PRBCs equals blood. Well, the problem with the red bias, what I see it is that red comes out of patients, and so it's very natural to want to put red stuff back in. And so we preferentially want to reach for the red cells because it seems to make sense. The way that we talk about it, too, makes conditions us to think of that, right? When we say, oh, have they gotten their blood yet? Let's hang the blood. Let's hang the blood. Red blood cells, though, are not blood. They are packed red blood cells, and they are a different fluid than blood in several important ways. So if you look at stored red blood cells, they have this storage lesion that comes pretty early on in the storage process. They lose ATP, they've got inflammatory cytokines, microparticles, the chemistry is all mixed up. What happens is you get this drop in 2,3-DPG, you can't offload your oxygen as well, they may not carry oxygen as well. And the membrane break, the sodium-potassium pump actually leads to this membrane rigidity and makes the cells less deformable and less fluid. And you can imagine, so this is an electron microscope of like day 1 red cells, and they're those nice biconcave discs that we're all familiar with. We'll look at by day 35, because of that membrane rigidity, they've turned into what's called echinocytes, which is like, hedgehogs. They turn into these little rigid hedgehogs. The problem with that is that as a red blood cell goes through a capillary, it must be able to deform and tumble and move because that causes internal mixing of the hemoglobin and brings oxygenated hemoglobin from the center of the red cell out to the periphery where the oxygen can diffuse. And so if it can't be squeezed and deformed through a capillary, it will not offload its oxygen as well. You can imagine one of these echinocytes trying to pass through this capillary, and it's going to wedge into place. And it's thought that maybe that giving a stored red blood cell into a sick patient, even a septic patient when they're already clamped down, this may be the source of some of the microvascular thrombi that we know occur in very sick patients. So one of the things that we worked on when I was at Mayo was looking at what is the arrival hemoglobin of our sick trauma patients. And it turns out their hemoglobin was just fine. It was their coagulopathy that was a problem. And so what they had was not a lack of red cells, not a lack of oxygen carrying capacity, but it was coagulopathy. And this has been borne out in military studies. This is from Journal of Trauma in 2003. Those soldiers that showed up with a coagulopathy had a much worse outcome in terms of mortality than those that didn't. And this has been shown time and time again. Karen Brohe in the UK has actually shown is that injury severity goes up, so does the likelihood of coagulopathy. And what's interesting is that an early coagulopathy, if reversed, actually results in a similar mortality risk down the line. So early administration, early fixing or correcting of that coagulopathy is what these patients really need. And this is where we have now moved to the idea of a balanced resuscitation ratio of trying to match 1 to 1 to 1 or 1 to 2 to 1. The exact ratio is probably not as important as it is that you incorporated plasma and platelets early on in the resuscitation. And that's been shown in multiple studies that I won't belabor the point here. The PROMPT study was one of the first ones, and the second one is the PROPER study. I'll just summarize basically what they've shown is that the exact ratio, whether it's 1 to 1 to 1 or 1 to 1 to 2, doesn't seem to matter, but there does seem to be some signal there that early use of the yellow fluids is beneficial for patients. This is also borne out. This is kind of one of the more recent ones. This is from the group out of Pittsburgh. They randomized early plasma utilization in a helicopter population, and they actually found that there was an improved outcome in those who got early plasma compared to standard of care, which, by the way, many of the standard of care helicopters were giving red cells en route. So it wasn't like blood products versus saline. It was actually plasma versus standard of care, which included red blood cells. So why is it better? Well, this idea that the red blood cells carry oxygen, that's true in each of us sitting here in the room, but is it true in a stored unit of packed red blood cells in the fridge? If they do carry the oxygen, do they offload it as well, and can they provide it to the tissues? Well, there's an interesting, this is a group led by Cabrales, I believe they're in San Diego. They torture hamsters, and they hemorrhage them, and then they resuscitate them. And what they've done is they split them into these 3 different groups, and sort of, the control arm is the doomed hamsters that don't get any resuscitation, and they all die. The other 2 groups, they take these hamsters and they give them either stored red blood cells that are stored in the normal way, And the other group, they give them red blood cells that have been incubated with carbon monoxide. So you bind up all of the oxygen binding sites on the hemoglobin. They're carrying 0 oxygen and resuscitate them with those red blood cells. And what's interesting is it doesn't matter how you measure it. I'm using the wrong button there. There we go. Doesn't matter what marker of resuscitation you look at, but the carbon monoxide red blood cells resuscitate the hamsters as well as the standard red blood cells. That's true with mean arterial pressure. It's true with this functional capillary density, base excess, whatever marker you want to look at, they resuscitate exactly the same. So it's not dependent on those red cells' ability to carry oxygen. They've done it. Here's some other, looking at basically the lab values that we would check in a human patient, and they resuscitate very much the same. The other interesting thing is that the carbon monoxide red blood cells actually result in less necrosis and less apoptosis when they section the animals and look at the tissue under a microscope. So it may be that the oxygen is actually harming those shocked animals, maybe through oxygen reactive species, or who knows what the mechanism is. And they've done it with methemoglobin by incubating with nitrites, and they do the exact same thing. So anyway, what the heck is going on? Isn't this counterintuitive to everything that we think we know about what we're doing for our patients? Well, and it turns out that it probably has to do with a couple of things. Number one is the glycocalyx on the endovascular membranes is very important. Microscopically, it's not a smooth, slick surface like we might think. It's kind of hairy. It's got all these glycocalyx glycans that stick out into the lumen of the of the blood vessel, and then it makes sense that the fluid that passes through that kind of network is gonna be important. And it probably what happens during trauma or massive hemorrhage of any kind is that glycocalyx gets sheared off, and that affects the permeability, which is where you get the third spacing and all of those kinds of things that happen. And so what's interesting is that when you look at these, experimentally, when you look at these, that glycocalyx is restored and rebuilt when you use plasma, but it isn't restored with crystalloid, and it isn't restored with red blood cells. So there's something in the plasma that seems to restore that glycocalyx. We don't know exactly whether fresh plasma is better than dried plasma. There's people looking into that. Fresh, never frozen plasma versus thawed plasma that's been frozen. They both seem to work. Fresh seems to work better than thawed, but it's all plasma. And it probably is the fact that because of that glycocalyx and what's going on is that the composition of the fluid, the physical characteristics of it are what's important. And so you can give red blood cells that don't have oxygen because it restores the right, maybe it's osmotic grade, maybe it's just the thickness or the viscosity. Who knows exactly what it is, but there's something about the fluid dynamics of restoring that seem to matter. So we know that 1:1:1 is way, 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 way better than crystalloid. The question is it as good as what is coming out of the patient? And that remains to be seen here. So this gets back to my packed red blood cells equals blood. This is what happens. When you take 1 unit of red cells, 1 unit of plasma, and the right amount of platelets and mix it back together and compare it to whole blood, you'll see there are important differences here. Number one is you get a much higher dose of citrate because you're getting 3 products, 3 times the citrate mixing back in. The citrate, an anticoagulant, is no good for a patient that's bleeding. In the military, they found that the average massive transfusion patient under the old paradigm got a dose of about 800 cc's of citrate. So almost a liter of anticoagulant fluid was going into these soldiers. Obviously, that's much lower with whole blood. You have higher hematocrit, you have a higher platelet count, and you have higher clotting factor activity. So Aristotle, the first blood banker, was the one that taught us this, is that the sum is greater than, or the whole is greater than the sum of its parts. So whole blood is definitely better than reconstituted whole blood. The other interesting thing about whole blood is that the platelets that are in whole blood are stored in a refrigerated fashion. And you'll know, if you do this a lot, platelets are stored at room temperature on an agitator. It's that room temperature storage that makes them only be good for 5 days, because after 5 days, the platelets are still fine, but the infection risk from bacterial contamination goes way, way up, and that's why they're thrown out. What's interesting is that the reason that is done that way is not because it's better for platelets or better for patients. The reason it's done that way is that the studies early on found that room temperature platelets were actually better at raising the platelet count on CBC for a longer period of time. So in patients that are cancer patients or ITP or those kinds of things, you can actually spread out the interval between platelet transfusions. What's fascinating, though, is that those platelets may or may not be doing any good for the patient that's circulating around. So if your goal is to raise this number and sort of, move the number into the normal range, then great. But if your goal is to stop them from bleeding, using room temperature platelets may not be the answer. It turns out that when you store platelets in the refrigerator at 4 degrees Celsius, the platelets are kind of partially activated. And the reason that the platelet count doesn't stay up as long in refrigerated platelets is it may be that they're off doing platelet work and plugging holes and getting consumed rather than sticking around in circulation for a long time. Cold platelets are actually FDA approved. The problem is that a lot of the blood banks don't want to maintain sort of two inventories, and so very few blood banks have gone to cold stored platelets. So if you look at whole blood, because of the platelet issue and because of all the other issues that we just looked at, the whole blood is closer to what's coming out of our patients by a long stretch. And because of that, it may be a better resuscitation product. If you can think about, imagine yourself like in the back of a helicopter too, if you can hang one bag and do one sort of set of paperwork where you're matching numbers and lots and all that kind of stuff, or stickers, or however you do it, that's logistically a lot simpler than 3 bags, and so there's logistic arguments as well. The other interesting thing is that this is a technology that is potentially available in every rural, austere environment. One of the first forward-thinking groups to actually do this was Royal Caribbean Cruise Lines. They found, they'd be out in the middle of, the ocean somewhere, and somebody's back to their 9th or 10th trip to the buffet, and, all of a sudden they pop a GI bleed from whatever. There's no blood available on the ship. All they have is what's walking around inside the other cruisers. And they were actually some of the first to do this and show that it was safe and feasible. The military, any military folks here? Military has been way ahead of the curve on this. Military's been using whole blood now for over a decade. This is probably old data, but over 10,000 units of whole blood has been infused. Much of it has been warm, fresh whole blood in sort of buddy transfusions, but there's been a fair amount of cold stored whole blood as well. They have seen very low risk of transfusion reaction, and the people that have used this say it's like miracle juice. You give this warm whole blood and it goes and they stop bleeding and they resuscitate, and we've seen sort of similar things happen in our population down in Salt Lake. So the bottom line, what does an ideal resuscitation look like? I would say if you're truly treating massive hemorrhage, you should minimize the amount of crystalloid. Unless they're actually spouting crystalloid out of their body, then you can replace that. But otherwise, you should minimize it because it's not doing them any good. Early emphasis on hemorrhage control, putting a hand on what's bleeding, direct pressure, tourniquets, wound packing, all those things that we're teaching in the Stop the Bleed class and those kinds of things that you may have seen. Whole blood and early whole blood, if it's available, is probably ideal. If you don't have that, maybe early platelets, early plasma, cold platelets if they're available. So when your pack comes up and it's got yellow stuff and red stuff, maybe what you should be reaching for is the yellow stuff first and then catch up with the red. And so it's take our normal paradigm and flip it a little bit. If you don't have whole blood, using a 1-to-1-to-1 ratio is definitely best, or 1-to-2-to-1 or something like that. And then we use these TAG and ROTEM. These are thromboelastography or rotational elastometry. They're showing us what's happening in real time with blood as it tries to clot, and then we can sort of target what we need to replace. TXA I don't really have time to get into. I'm happy to talk about that at length later, but obviously definitive hemorrhage control as soon as possible. This has really come up in the TCCC, which is the class that they give the corpsmen and the medics and things like that in the military, and whole blood has become the preferred fluid if it's available. At IMC down in Salt Lake, this is what we've done. I put October 1st. That was our original goal. We actually went live on January 14th for different reasons. This is what we do now. The first pack that comes up is 4 units of low titer, O negative or O positive if it's a male patient, whole blood. It's 500 mils total in each unit, so you get about 2 liters of whole blood that comes up in that first pack. If we use all of that and still require more, we revert back to our current 1-to-1-to-1 process that you can see there, and we give it to anybody who's bleeding. They don't have to just be trauma patients. So we may be one of the first hospitals in the country that has expanded it outside of the trauma world, and we're giving it to GI bleeds, peripartum hemorrhage. In fact, just looking at the data in the last 3 months, we've done, I think, 3 postpartum hemorrhages and actually have submitted an abstract for that. So it's exciting. It's coming along. We're working on getting whole blood in the helicopters, in the life flight helicopters. I'm working with Bill Beninati to try to get that done. We're kind of also working on traditional components in the meantime. The idea is that, many outlying hospitals, they'll stock O-negative red cells, but they don't have the plasma or the platelets. And so if we can provide that product en route and bring it to the patient, then maybe doing better there. There are some concerns, and I probably don't have a lot of time to go over those. I think I have till 9:30, but my clock is off here a little bit. A couple of the concerns, and this comes from the blood bankers, is what about hemolytic reactions? If you think about it, the universal plasma donor is AB positive, right? They've got none of the antibodies. Well, O-negative whole blood has all of the antibodies, and so potentially you could have hemolysis. It's interesting that we are all currently giving incompatible plasma every time you give a platelet. You're giving an O-negative platelet, O-negative platelets come in O-negative plasma, and you're giving potentially incompatible plasma with pretty much every platelet transfusion, and yet we're not seeing reactions with that. There are a bunch of reasons why that's probably true, but so far we haven't seen any hemolytic reactions in our whole blood population. RH incompatibility is an interesting thing. 30% of our massive transfusion patients are women of childbearing age. If you look at our population incidence of RH negative, it's about 16%, and 1% of our trauma patients are MTP. So by the time you do the math, you're looking at a very small percentage of patients who are at risk for RH incompatibility. And as many of the transfusion medicine folks say, is if you do convert and you are a woman of childbearing age, that's a disease of survivorship, and they can deal with that problem. The risk of death from hemorrhage is 40+%, and so we'll take those odds. And if it happens that a woman gets an RH positive who's R negative, then that's something we can deal with. We've not seen graft versus host disease so far. That's a theoretical concern. I think it's been reported once or twice in the literature, but we haven't seen it yet. And then how do we run it? We use a Belmont rapid infuser. And so far, the Belmont has not been cleared to give platelets. The nurses in the room will know that you have to run the platelets not through the Belmont, through a separate line. We've started using whole blood through the Belmont. We've done some preliminary studies comparing before and after running through the Belmont. It doesn't seem to affect the Belmont. It doesn't seem to affect the platelets. It doesn't seem to affect the patient. So we're continuing to do that, but we have ongoing studies there. It's not recommended that you use a pressure bag, but again, I think it's because it hasn't been studied, not that there's anything wrong with it. Some other concerns. Right now, whole blood is not readily available. If you were to go ask your blood supplier to give you whole blood, they wouldn't be able to do it right now. It took a lot of work. It took me about 2 years working with the American Red Cross in Salt Lake to get this done, and they've kind of moved mountains to make it happen for us, and I very much appreciate their support. My sense is that there are a lot of people who are interested across the country, and it may be that we're finally moving the big ship of the American Red Cross to get them to make this more readily available. Selfishly, I will say it doesn't hurt to ask your blood supplier and say, hey, we're really interested in whole blood, can we get it? The more people asking, the more maybe positive inertia we can get with them producing the product. Right now, we actually have to import the product from Portland because they're not making it locally. So we're working on getting that changed. We're actively collecting data and building a database on these patients. I just looked at it earlier this week, and we were up to, at the beginning of May, we were up to 32 patients who'd gotten whole blood, and that's over 100 units of whole blood. What's interesting is that about a little less than half of them are trauma patients, and more than half are medical. We actually thought it would be much more trauma than medical, but we've seen more medical patients get whole blood so far. What we're currently doing is that as soon as we know the patient's blood type, which may be way after the 4 units are gone, but as soon as we do know, we are switching over, it's not set in stone. We're kind of allowing the provider to decide, and we're trying to figure out exactly what other effects the whole blood may have. So we're still working on it. In summary, I guess, and I'm happy to take questions. Is what I'd like you to think about is instead of bleeding, instead of thinking of it as like red stuff pouring out, think of it like an organ system, and that massive hemorrhage represents blood failure. And so the treatment of this is to restore that circulating volume deficit in a way that fixes the coagulopathy that all of these patients are going to develop. And so reach for the yellow stuff early, if not first. The way that I currently do it, if I don't have my whole blood, is I will give the pack of platelets first, because platelets come with a lot of plasma, and then I will move to my plasma, and I will give all of it before I give them a red cell. And that's kind of how I've done it. And what's interesting is that a lot of times I end up giving a unit of plasma or two, and actually the patients sort of stabilize and get better. I don't end up giving the red cells in many cases. So it's a little bit different than the way that I was taught and the way that I was trained, but I think it's probably better for the patients. And so my bottom line, as I tell everybody, all the trainees that we work with down there, is that if blood is coming out, you put blood back in, or as close as you can get to actual blood. One of my friends and colleagues, he's in St. Louis, actually came up with this graphic, which I think crystallizes it perfectly, that saline is for cooking pasta. I'd also say it's for dehydration, but it's for cooking pasta, and blood is for resuscitation of massive hemorrhage. So with that, I'm happy to take questions. Here's my contact information. I put Sarah Ilstrup, she's the director of transfusion medicine for multiple hospitals down in the valley down there, Primary Children's as well, but she works a lot with them. So happy to take comments, questions, slings and arrows of people who are thinking I'm on the wrong path here. So thank you very much.
So we'll have a break until 10 o'clock, and then we'd invite you to go see the posters. There will also be presentations in here at 10, I believe, though. Is that correct? Yes. Okay. Thank you.